Welcome back to the PFC Podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC Podcast. This is Dennis, and this episode was recorded with the sponsorship and support of the Special Operations Medical Association. Thank you guys very much, and I hope you enjoyed the talk.
I know you said that brains save both, and then you put me up behind the podium. I don't think you're helping anybody out here. So I'm going to give you some lessons learned. This is more on the tactical level from this exercise called Ridge Healer. This is a congressionally funded exercise that we run in West Virginia. So we're going to talk a little bit about what Ridge Healer is, and then kind of break down a few take-home points that we've seen as we've seen a number of these small footprint surgical teams and resuscitation teams come through the exercise. So what is Ridge Healer exactly? It's a training program, it's an exercise, and it's a laboratory. So we take these small teams, they're usually like 3 to 6 people or so, do a few days of didactics, give you the once over the world of some of the threats that we're facing in the IW environment, have you do some medical preparation of the environment, build out your caches, which are then placed in the field, build out your non-standard low-vis CASEVAC platforms, and then we'll infiltrate into the hills of West Virginia for several days, set up clandestine sites, throw casualties at you, have you moving around doing non-standard CASEVAC, supporting operations as notional units prosecute targets. Now, this is an offshoot of the Ridge Runner program, which is an unconventional warfare exercise that we've been running in West Virginia for a number of years. It is also a laboratory. It's an opportunity to try things out, see what works and what doesn't work. Now, I've got about 40 minutes of stuff to give you in 20 minutes. I'm not sure if I've had too much caffeine or not enough, but we're going to go fast. So you can see the kind of places that we set up here. We have abandoned mines, warehouses, abandoned houses, barns, this sort of thing. And that's where we're setting up in a semi-permissive to denied environment with a nominally superior enemy we're having to deal with. And we move around a lot through the hills. West Virginia is a big state. It's very mountainous. The terrain is great for this exercise. We also have a very military-friendly community that supports this. We also do some of this stuff down in South Carolina as well. Now, a few tips about working in the IW environment. Everything in this exercise is a decision. Every dressing you use, every medication you give, every movement that you make, you're put to a decision. You got to weigh the costs and the benefits of doing these particular things. And you have to think about in advance. It's not just about this patient. It's about all the patients they're going to follow on. Your logistics chain is very spotty, and you have to make some hard decisions there. So medicine is not the only decision here, because your capability to support that IW operation is going to affect the ground force commander's risk appetite. So if you burn all of your resources and your surgical team is no longer mission capable, then that ground force commander is going to shift how they approach a problem tactically, and they may not want to accept as much risk in that operation. Going one wall in. So for a couple of reasons. One is IDF and drones. We do bomb and drone these teams when they're in the box, and you don't want to be standing right next to the wall that's hit by a drone. So being one wall in that setting gives you a bit of standoff there. But the other thing is you don't want somebody walking in and like seeing you doing gangster stuff while you're in there. So having an inconspicuous kind of vestibule, if you will, in there. So just in case you have an unexpected visit from somebody, then you don't look like you're doing gangster stuff. I had to quickly kind of explain to the UPS guy why I had this bloody casualty on the floor and blood all over the floor right before the team had arrived to take care of him. So it was a good illustration of that. Don't let your surgeon go to the door. So the surgeon is on these teams, if it's a surgical team, the most irreplaceable assets that you have on there. Now, I'm an emergency and pre-hospital physician. I could do a lot of resuscitation, but I can't do a laparotomy. And really nobody else on the team could do that. I'm pretty sure the nurses or medics on the team could do a really good job of resuscitating to about the level that I can as well. But the surgeon can't. But there is this desire to go to the door and, see the patient, figure out what's going on. And I see this in my civilian job too. The surgeon comes out to the ambulance bay to see what's going on, moves up to the helipad. It's like, no, stop. Okay, leave them in there, because that casualty that comes up, you don't know if they've been cleared or not. And if that casualty clacks off, their suicide vest right in front of your surgeon. Now your team's not operating, and that's going to be a bad thing. So some other things here. This isn't the hospital for a couple of reasons. So if you look at this example to that side, the team that you have there, you got to look at cross-training, and there's a blending of scope of practice. So what you have here is an 18 Delta who's performing surgical management of hemorrhage on this amputee casualty, and being assisted by other non-medics, medics, and a nurse there as well. So when you're doing this cross-training, which is so important on this team, that blending of scope is helpful. The other thing that you find here is you look on this side, you've got the sterile gowns, the sterile drapes, the sterile gloves, all that kind of stuff. All that stuff's going to weigh you down. It takes a lot of space in your kit, and it's really not necessary for you to have. So when you come to this program and you've spent most of your career working in a hospital, you have a certain image of how things look in that hospital. But really, those things are luxury. The other thing is conserving and reusing. So we're really used to this in a hospital setting where you take a syringe, you take a draw needle, you draw up your medication, you throw away the draw needle, you attach a different needle, you give the medication to the patient, then you throw all that away. But there's no reason that we have to do that here unless you want to take 1,000 syringes with you, in which you don't, because not only do you have those limited supplies, but it also creates signature that might be exploited by the enemy. Same thing with these sterile gowns and drapes. The more trash that you generate, then the more stuff that could be potentially exploited with biometric data, DNA, etc. by your enemy. Team composition, leadership, and communication. Like I say, we have resuscitation teams as well as surgical teams that come through this. When it's a resuscitation team, we'll take a notional host nation surgeon, who usually is a trauma surgeon, that will come in, and then you have to assist that surgeon in what you're doing. Over casualties, they have full cut suits, so we're doing thoracotomies and laparotomies and that sort of thing for surgical management. So teaching your team how to assist in surgery can be helpful, even if you're not a surgical team. We talked about the flexibility of roles, but also cross-training and doing split team operations. The ask may be we've got multiple targets being prosecuted simultaneously, or we have maybe a vehicle that has room for 2 people, figure out which 2 people you're going to send. So take that stuff out in advance. If you were going to send just one element out there, who is it on your team that you would send with that element? And also plan for the fact that the team that's left behind is going to be receiving some casualties at the same time. Now, on these teams, the surgeon operates. The surgeon should not be the team leader. Now, if you're a surgeon here and that hurts your feelings, I'm really sorry, but deal with it. The reason is that in the civilian hospital environment, surgeon typically is a team leader, especially in the operating room. That makes complete sense. In the resuscitation bay doing trauma resuscitations, that makes sense. If you're a trauma czar for your trauma program, that makes sense. But the problem is that as soon as the surgeon goes head down into that operation, then they're not able to lead the team because they're concentrating on a very complex problem in front of them. So you need to have somebody else that is leading the team, whether that's an emergency position or a SOC medic that's a senior non-commissioned officer or something like that, that's still driving all of those pieces, that's running those resuscitations outside of the operating room and preparing to send the next casualty in there. So the other piece is don't bother the surgeon while they're operating. This is like bothering the pilot while they're flying the helicopter. Don't do that. They need to be concentrating on that casualty. If they want to know what casualty is waiting for them out in the next resuscitation room, the surgeon needs to trust the team that we're going to do the resuscitation. We're going to triage the most appropriate person going to the operating room next. Reduce the audio clutter. There's a lot of stuff that you'll hear in trauma base in at least here in the United States where everybody's yelling this like, I need Epi and I need this and we need to do this and can we get a blood pressure? And you're kind of talking to the whole room. And really in this setting, that gets to be very, very distracting. It increases cognitive load, and that's a problem. So reduce the unnecessary clutter. If it doesn't need to be said to the whole team, don't say it. If you need something from somebody specific, then address that person specifically in a low voice. Hey, Paul, can you go ahead and get 2 grams of TXA, please? Donna, can you recheck that tourniquet and make sure it's still working for me? But address those things, because when you reduce that audio clutter, the stuff that really needs to stand out, like, hey, the end tidal waveform just went flat, that everybody does need to know about it because everybody needs to work that problem immediately, that stuff stands out. So the that communication piece is something that folks seem to work out really well as throughout the exercise. That what you think about, but you don't practice, doesn't get done. And everything should be rehearsed. Loading the patient into the casevac vehicle, unloading them, bringing them to the resuscitation bay, bringing them to the operating room. We see a lot of stuff that's really well thought through, but then not implemented because when the time comes, you've got a bit of cognitive overload going on and you're not thinking of those really cool ideas if you didn't put those into practice already. Checklists. Become a checklist guru. Any complex multi-system process should have a checklist. Now, especially if this involves multiple team members. So having a flyaway checklist if we're going to push forward mobile and take some stuff, because this helps. Not only do I make sure I don't forget anything, I don't sit there, I don't get redundant with it. And if somebody else has free hands, they can look at the checklist, know what in my sector hasn't been done yet, and then they can come and help out and add to that as well. So some non-standard casevac stuff. So we're using these low-profile vehicles. If you're not used to moving around in the back of a blacked-out van, then motion sickness is a thing. So bringing some meclizine with you is probably not a terrible idea. Putting some handholds in there. So if you're using an SUV, it's not a big problem. But when you're using a van or something like that, you're typically standing up, moving around the casualty. You need something to grab onto, and there's not always intrinsic ones in there. So put those into your casevac vehicle. Now remember, medevac is not a pause. It is the opportunity to continue improving the patient's position, improving their physiology, and getting them better. You're not just sort of waiting until the next step, because that is going to be a lost opportunity. The medevacs that we do through this exercise are usually a couple of hours long. So you have a real opportunity to improve that patient there. A couple things here. I want to call your attention to the shooter pleasure, as our Brit colleagues named it. Took fish dryer hose, duct taped it to the vent in the SUV, and then put that up under the HPMK. So that's blowing warm air up in the HPMK on the casualty. Those are the most comfortable casualties we had the whole time. I thought this was a genius idea, and that's why I wanted to put that here. I also want to point out that the person here, our operator, is driving and he's reaching back and is helping a bag. How good of a job do you think he's doing with both of those tasks? Probably not that good. How many lives is that driver responsible for? All of them, right? There are about 5 of us in that vehicle that he's responsible for. So again, decreasing his cognitive load needs to be focused on that issue. And so remember, this isn't just a pause. We do some air evac stuff here. We will operate in flight on 130, as well as do some rotor wing evac. And again, we're making the patient better the whole time we're doing this. Stay off the damn radio. I don't know what it is. Like, we are married to this full mist report that we want to give over the radio. Like, I have a 25-year-old male contract. I've given 2 grams of TSA, I've given a gram of Benson. Well, we're giving 50 milligrams of ketamine. We're giving this. Nobody gives a shit, okay? So what do I need to know? What does my surgeon need to know if we're bringing it back? 25-year-old male, gunshot wound to the abdomen, in shock, see you in an hour. Is there anything else that they need to know to get prepared for that casualty? No. And the more we're on the radio, the more we're distracting them, the more we're distracting us and not taking care of the patient, and the greater EM signature we are giving in order for other folks to pick us up. The Germans in World War II had this capability of picking up and localizing radio transmissions. You can bet that our peer adversaries have that capability as well. On the medical side, hypothermia is a really big deal. We do a lot of these through the fall, winter, and spring. It is cold out there, and our role players, our live role players, they get cold. And this is the advantage of using live role players, is they can tell you that they're cold. So getting really deliberate about your hypothermia care is very important. Thank God we're not dealing with what our Ukrainian colleague was saying yesterday with drugs freezing as they're drying them up. That would suck, and I would definitely quit. But it's a big deal. Even when we're doing all this stuff, sweating like Tiger Woods of the Morse hearing, the patient is getting a lot colder, okay? Add your triggers for certain actions. No, in your mind, work that out ahead of time. So when you're under stress, you know, what's my trigger for doing a thoracotomy? What's my trigger for doing a blood transfusion, for taking the patient to the operating room? Work that out ahead of time. So when you're under stress, the decision you have already made at some point beforehand. Know what your inventories are. Pain control adjuncts. We won't give you ketamine for everything. But the ketamine is a precious resource, and it is extremely versatile. But if we're going to be using that for our TIVA, if we're going to be using that for our conscious sedation, and we're going to be using that for pain on our hemodynamically unstable casualties, does everybody need ketamine? We've got other drugs that we can use. Can we use oral medications for this? Can we use non-steroidals? Add an antihistamine to that because it potentiates the pain management effect of a non-steroidal. Can we use regional nerve blocks, local nerve blocks, that sort of thing? So use all the tools that you have available to you. Remember that we're not just trauma, and this is a curveball that I'll throw at the teams. Is like, great, okay, you're thinking about trauma, you've got like 1 liter of crystalloid with you, and okay, I'm just going to give you a septic patient. Now you're going to have to deal with that. So think through that disease and non-battle injury, because that's going to be most of what you're going to see downrange anyway. In some of these cases, maybe blood is better than IV fluid if you have a robust walking blood bank. So if you've got a casualty with severe burns, rather than dumping liter after liter after liter of fluid into them, maybe you use blood as a colloid for volume resuscitation. That would be something that we probably wouldn't do in the United States. Maybe we'd use plasma, but we wouldn't think of like whole blood for that. But in that IW environment, if you've got a good walking blood bank, might be a good choice. Know your alternative antibiotics. I know we love Invans, but hey, you know what? I'm National Guard. Our budget sucks. So like I can't get a lot of Invans sort of teams, but look at the war surgery manual. What's king in the war surgery manual? Penicillin. You can get it anywhere in the world. And it's a 90% solution for this. So know what kind of alternatives you have. For dressings, send somebody down to the fabric store to get some gauze dressings or to get some gauze fabric, and you can make a lot of this stuff where you're at. After the operation here, switching to PCC mode often takes time. So particularly for medics and doctors have a hard time making that switch to that prolonged casualty care. You know who does this really, really well? It's nurses, because that's the world that they live in all the time. So as soon as that patient's off the operating room table, when nurses are part of that team, then they're immediately starting the mouth care, the skin care, making them comfortable, dropping the Foley, doing all those things that are so important in PCC. So doctors and medics, think like a nurse when you get into that. But when that operation is done, you feel like some of that pressure is off of you. It's not. Your work has just begun in that, because again, in this setting, we haven't taken care of casualties for days. So you have to get into that mode. Stop laying the patient flat. No hospital in the world are you going to see a patient laying flat. They're always sitting upright for a couple of reasons. One, your diaphragm is fighting all those abdominal contents. You get more atelectasis. It's harder for you, and it's more painful if you've just been operated on. So 2, your stomach contents are on the same level as your oropharynx, and so it's a lot easier for you to aspirate. So you sit all of your patients up. It's better for them. It's more comfortable. Set your goals. What are your goals for the next 4 hours, next 12 hours, next 24 hours, and set your battle rhythm. Use the lulls to always improve your fighting position. I know it looks okay when they're laying on a Talon, but that really Talon is not comfortable for a long period of time. Always be figuring out, how can I make this patient more comfortable? How can I pad them? What can I do? Do some massage, do some mobility, all that kind of stuff to make them more comfy. Use the PCC flow sheet. I don't know why we seem to be averse to using this. It's fantastic. It sets you goals up. It tells you what you need to be doing over the next couple of days, and you can track trends. Trends are more important than spot checks, right? I can look at spot check of vital signs that looks okay, but if that's a significant departure from what the vitals were 2 hours ago, then I can anticipate that my patient may be having the problem, and I need to be more aggressive about resuscitating him. Set up your task list. Be patient. Is the other thing. We have this sort of exercise scar where you do something and then you get an immediate result from that. And that's not how physiology works. That's not how real patients work. So do something, but be patient to see the effect of what happens, and stop hovering over the patient. Once you've done the thing, as the primary resuscitator, whoever that is, the main physician, surgeon, medic, whoever wants to kind of check and sort of see is everything okay and all that. Stop that. Set your conditions for being woken up and fall back into that battle rhythm and get some sleep, because you don't know when the next casualties are going to be coming. But make sure that whoever's taking care of the patient, especially as they're non-medical, has those wake-up criteria and knows when to come and get you after that. There's some basic soldiering stuff that we see. Working out of your pack. Pete, one of our 18 series guys that helps teach this course, says, don't make this look like a homeless camp, right? If you need something out of your pack, you pull it out of the pack, you use it, you put it back in the pack. And the reason is sometimes you're going to have to move fast. And if your place looks like a yard sale of Mystery Ranch and Patagonia and all that stuff, it's going to take you a lot longer to unask that AO. You're probably going to leave some stuff behind, and that's stuff that can be used against you. Learn how to do a KLE, especially if you're American. Look, I understand. I know how Americans are viewed in the world. We're brusque, businesslike, even rude sometimes. And we're doing a KLE with somebody who's supporting us, is giving a lot of those stuff. Gotta be nice. Bring a gift, butter them up, be cool. Learn how to do those kinds of skills, and how to do bona fides as well. If you're further interested in this program here, this is Chief Warrant Officer Gene here. He's the director of the program. You reach out to him, and I'll take questions later. Thank you.
That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC Podcast, out.